Hello, I'm Ty Carroll, an endocrinologist here at the Medical College of Wisconsin, and today we are going to talk about adrenal insufficiency. Our objectives for today are going to be to identify the signs and symptoms of adrenal insufficiency, discuss the diagnosis and differential diagnosis of AI, and then review therapy, including acute adrenal crisis, chronic steroid therapy, and then stress dosing. So a little history background about the adrenal glands. Bartolomeo Eustachius in 1563 described the adrenal glands, saying that both the kidneys are capped on the extremities towards the cava by the gland. So he really was the first person to describe the adrenal glands in detail. Then more recently, Thomas Addison in 1855 talked about the constitutional and local effects of disease of these suprarenal capsules. So he really was the first to describe adrenal insufficiency in detail. So when it comes to the adrenal glands, we need to talk about the hypothalamic pituitary adrenal axis, or the HPA axis. As you may know, the hypothalamus stimulates the pituitary gland via CRH. And that causes the pituitary gland to produce ACTH, which tells the adrenal cortex to produce cortisol. There's negative feedback from cortisol on the pituitary gland and on the hypothalamus, and it's a classic negative feedback loop that keeps ACTH levels in the normal range and cortisol appropriate based on the situation. Adrenal insufficiency is when that feedback loop breaks down. So adrenal insufficiency is the lack of adequate cortisol production for any reason. And when there is stress to the body, cortisol levels have to go up. And if those levels do not go up appropriately, that's adrenal insufficiency. Or if there is damage to either the pituitary gland or the adrenals that causes suboptimal production of cortisol, even in the basal state, that leads to adrenal insufficiency. We refer to central AI, or sometimes called secondary AI, as inadequate cortisol secretion due to inadequate ACTH production. So it's not the adrenal glands themselves that are the problem. Whereas in primary AI, the problem is the adrenal gland. There's failure of the adrenal glands due to destruction, really, of both adrenal glands. And there's inadequate glucocorticoid, which is cortisol production, and inadequate mineralocorticoid or aldosterone production and secretion. And then adrenal crisis refers to acute physiologic decompensation that occurs when a patient is severely ill. This often leads to very low blood pressures or shock, and it is a life-threatening emergency that really needs prompt diagnosis and treatment. So what are the signs and symptoms of adrenal insufficiency? Well, symptoms that you get from not enough cortisol. You can have GI symptoms such as nausea and vomiting, abdominal pain. You can have headaches. You can even have fasting hypoglycemia. In patients who have primary adrenal insufficiency, or PAI, they can get mineralocorticoid deficient symptoms such as low blood pressure, weight loss, and can also have problems with electrolytes. So patients with adrenal insufficiency develop hyponatremia. If they also have primary adrenal insufficiency, they often have hyperkalemia. It's important to note that if a patient has hyponatremia, adrenal insufficiency should be excluded in all of those patients unless there is a clear and obvious cause of the hyponatremia. Patients will also develop weight loss, and in primary adrenal insufficiency, they develop hyperpigmentation. So the skin gets darker because ACTH levels go up, and the precursor to ACTH contains stimulation to the melanocytes that darken the skin. So in primary adrenal insufficiency, it's the adrenal gland here in the middle that's the problem. Cortisol levels go down, so there's less negative feedback on the hypothalamus and pituitary gland, and ACTH levels go up drastically in order to try to tell the adrenal glands to start to make additional cortisol. There's also a decrease in aldosterone, because the adrenal cortex cannot synthesize and secrete aldosterone as well. And so patients with primary adrenal insufficiency will also have high renin levels because the kidney is trying to tell the adrenal gland that it needs additional mineralocorticoid or aldosterone to maintain blood pressure. So what are some of the causes of primary adrenal insufficiency? Well, the most common cause is autoimmune. So patients have T and B cell destruction of the adrenal cortex. Those patients have elevated 21-hydroxylase antibodies. Another fairly common cause is bleeding, but it has to be bilateral hemorrhage of the adrenal glands. That's generally evident on imaging. That can be seen in patients who have anticoagulation therapy or patients who have antiphospholipid syndrome. And then there are a number of other causes, including the infiltrative diseases. So patients can have bilateral adrenal metastasis from malignancy that can spread to the adrenal glands. But again, a large portion of both adrenal cortex or cortices need to be destroyed. It can be seen in fungal infections as well as other causes. But these are the more complete listing that we won't go into in detail here today. So in secondary adrenal insufficiency, the problem is here at a higher level, at the pituitary gland. There's a decrease in ACTH production, and that leads to lower cortisol levels. So as cortisol levels drop, ACTH levels should be high if the pituitary gland is working correctly, but it's not. The ACTH levels in some circumstances may not fall subnormal, but if the cortisol level is low, especially in the face of stress, ACTH levels should be very high. Contrary to primary adrenal insufficiency, in patients who have secondary adrenal insufficiency, aldosterone is still produced. The feedback loop with renin and aldosterone in the kidney and the adrenal gland is still intact, so your adrenal gland still continues to make aldosterone. Over time, if the adrenal gland does not have adequate stimulation from ACTH, the cells of the adrenal gland that make the cortisol tend to atrophy, and even with increase in ACTH levels, at some point may not be able to make cortisol because of that degree of atrophy. So what causes this secondary adrenal insufficiency? Well, tumors of the pituitary gland, so craniopharyngioma, can certainly affect the production of multiple pituitary hormones, including ACTH. The most common cause is probably exogenous glucocorticoids. So if you're taking exogenous steroids, that suppresses the pituitary gland, and then when you stop taking those exogenous steroids, the hypothalamic pituitary axis is asleep, if you will, and takes some time to wake back up. A more common occurrence here in the past few years is the use of immune checkpoint inhibitors, and these agents can cause isolated ACTH deficiency. So they get isolated central adrenal insufficiency. This is generally irreversible in patients who develop this, and these individuals need prompt recognition and treatment. So how do we diagnose adrenal insufficiency? Well, the first thing I'll say is that in patients who are sick, the mantra has to be treat first, diagnose second. If there is a suspicion of adrenal insufficiency in a patient who is acutely ill or critically ill, they should be treated immediately without confirmation of the diagnosis, and we can make a diagnosis later on, because delay in treatment of adrenal crisis can lead to death. So this is a diagnostic algorithm for patients who have the suspicion for adrenal insufficiency and patients who are stable. So if we have patients here who we suspect have adrenal insufficiency, and again, I'll point out these are stable patients, the best test initially is a morning cortisol. If that cortisol is high, greater than 18 micrograms per deciliter, adrenal insufficiency is excluded. If those levels are low, less than about 3 to 3.6 micrograms per deciliter, the diagnosis is confirmed, and those patients have adrenal insufficiency. Patients who are in this gray area still may have adrenal insufficiency. One strategy is to check a DHEA sulfate or DHEAS. If that's normal to high, adrenal insufficiency is unlikely. If that DHEAS is low, then an ACTH stimulation test, also called a cosentropin stimulation test, can be undertaken. If the cortisol at 15 minutes after cosentropin administration is above 15 or above 18 after 60 minutes, again, adrenal insufficiency is extremely unlikely. And I'll point out that these thresholds of 15 and 18 are dependent on the type of assay used, whether it's a tandem mass spec or whether it's an immunoassay, but these are guides. There is no hard, fast, perfect cutoff even for any given assay, and you need to use clinical judgment, but these are good guides to know what to do. In patients who don't stimulate appropriately, or patients who had a low initial AM cortisol, adrenal insufficiency is confirmed, and we should measure their ACTH for differential diagnostic testing. If the ACTH is elevated, they have primary adrenal insufficiency. Patients who have a low ACTH or an ACTH that is in the reference range, those patients have central adrenal insufficiency. So in patients who have been diagnosed with adrenal insufficiency, they have an elevated ACTH, those individuals have primary adrenal insufficiency. The next step is to figure out why. So the most important next step in the testing is measurement of 21-hydroxylase antibodies. So 21-hydroxylase antibodies are present in the vast majority of patients who have autoimmune adrenal insufficiency. So if those antibodies are positive, those patients have classic Addison's disease or autoimmune primary adrenal insufficiency and can be treated as such. Patients who do not have 21-hydroxylase antibodies should have a CT scan of the adrenals to look for tumor, mass, or bleeding, and that diagnoses the vast majority of the rest of patients with primary adrenal insufficiency. Well, what about differential diagnostic testing in secondary adrenal insufficiency? So these are the patients that have adrenal insufficiency, they have a normal or low ACTH. Those patients should have a pituitary MRI and the remainder of their pituitary function checked unless there's a clear secondary cause. So patients who had been on steroid therapy, which is now discontinued, patients who have been on immune checkpoint inhibitors, those individuals can be presumed to have secondary adrenal insufficiency from an identified cause and don't need other additional testing. But if those factors are not present, patients should have an MRI and then the remainder of their pituitary function tested. So thyroid function with TSH and T4, a measure of growth hormone production from an IGF-1 level, a prolactin, in men, morning testosterone and LH. In women who have amenorrhea, estradiol, LH, and FSH are advised. Just a word about glucocorticoid-induced adrenal insufficiency. So this causes secondary adrenal insufficiency. It's important to remember that any supraphysiologic dose of glucocorticoid can cause adrenal insufficiency. The higher the dose is and the longer the duration of therapy, it's more likely to develop adrenal insufficiency. If you have a patient who's on steroids for less than 3 to 4 weeks, really at any dose, there's no need to taper the steroids from a standpoint of adrenal insufficiency. Those steroids can be discontinued and the likelihood of developing adrenal insufficiency is extremely low. So patients don't need to be tested for adrenal insufficiency if they still need treatment for their primary disease, so whatever they were put on steroids for. Patients, if they're going to continue on continued steroid therapy, there's really no reason to have to test those individuals because they're going to remain on steroids. But when a patient is coming off of steroids, they've been on a course that's longer than 3 to 4 weeks, and that patient has their steroids reduced to a physiologic dose, somewhere around 3 to 4 milligrams of prednisone or less than about 25 to 30 milligrams of hydrocortisone a day, you should obtain an AM cortisol. If that AM cortisol is above 10, you can stop. Those patients don't have adrenal insufficiency. If that cortisol is less than 5, those patients likely have glucocorticoid-induced adrenal insufficiency, and they need to be continued on steroid therapy and try to wean off over an extended period of time. So, moving on to treatment. In patients who have adrenal crisis, these are patients that come in, they maybe had a long history of steroid therapy and have now recently come off, or they are acutely ill. They need IV fluids immediately. If you can draw a cortisol level before the therapy is given, great, but it should not delay the patient getting steroid therapy. And you certainly shouldn't wait for the result of that lab to give steroids. So any patient with suspected adrenal crisis, we would suggest giving IV hydrocortisone 100 milligrams immediately, followed by 50 milligrams IV every 6 hours. Or alternatively, they can get 200 milligrams per 24 hours with a continuous IV infusion, whichever is preferred. In the US, usually an initial bolus and then Q6 hour hydrocortisone is generally preferred, whereas in some other parts of the world, the continuous infusion is more regularly used. And then the patient's clinical status should be reevaluated after 24 hours. And if they are doing well, they no longer are in adrenal crisis, you can wean the hydrocortisone dose and continue to go down as the patient clinically improves. Once they're doing well, you can transition them back to oral hydrocortisone or maintenance steroids, depending on what they were on previously. In patients who have adrenal insufficiency chronically, so these are patients that are not acutely ill, but patients who are diagnosed or patients who are found to have adrenal insufficiency early on in their course, we prefer to treat with hydrocortisone over other longer-acting steroids. And a dose of 15 to 25 milligrams a day in 2 to 3 divided doses is usually used. So often 10 to 15 milligrams in the morning, and then 5 to 10 milligrams in a second, or 5 milligrams in a second and third dose later on in the day. Regimens such as prednisone or dexamethasone are less preferred. In some instances, they have to be used and can be used in a dose of about prednisone 5 milligrams a day or dexamethasone 0.75 milligrams daily. But again, those are not preferred agents. And then we really monitor patients' symptoms. We monitor their blood pressure, their serum sodium to ensure that those are all normal. Patients who have primary adrenal insufficiency, who have failure of the adrenal gland itself, also need mineralocorticoid, and those individuals should be treated with fludrocortisone. The standard dose is about 100 micrograms once daily, but doses vary from about 50 to 200 milligrams daily. We monitor patients' blood pressure, we monitor for peripheral edema, and also their potassium levels to make sure that the fludrocortisone dose is adequate. Some individuals also recommend monitoring a renin level with a goal renin of less than about 4 in patients treated with mineralocorticoid. In some individuals, particularly women with adrenal insufficiency, we can consider using DHEA in a dose of 25 to 50 milligrams daily, and that's to replace the adrenal androgen that's not made in primary adrenal insufficiency. Patients also need to be educated on what to do if they have an illness, which we'll talk about in just a minute. And we suggest that they should have a medic alert bracelet that notifies first responders that they have adrenal insufficiency. And all patients should have an emergency intramuscular hydrocortisone injection kit. So if they develop problems with nausea, vomiting, and can't hold down their hydrocortisone, that they can give an IM dose and then be seen promptly for medical attention. So stress dosing. So when patients develop an illness or they're going to have a procedure, the body would normally make extra cortisol, but in individuals who have adrenal insufficiency, the body can't do that and they need to take extra hydrocortisone. So we recommend that if patients have an illness requiring bed rest, that they increase their daily hydrocortisone to a total of 40 milligrams daily. So that can be given in 2 or 3 doses, usually 3 doses, 20 milligrams right away in the morning, 10 milligrams midday, and then 10 milligrams in the mid-afternoon. They can continue this for 2 to 5 days until they're feeling better. If they're on prednisone, we would increase to 10 milligrams total for the day, and again, continue for 2 to 5 days. So if patients are having a minor surgery, including those with local anesthesia, they can get hydrocortisone 40 milligrams total for the day, similar to what is given for an illness with a fever or an illness requiring bed rest. And then if they're going to have a bowel procedure that's carried out not under general anesthesia, so just under twilight sedation, they can continue their usual dose or double the glucocorticoid dose on the day of the procedure. They should be given an equivalent intravenous dose if they're going to be NPO for a prolonged period of time. So patients who have a severe or critical illness, so patients with vomiting and diarrhea, patients who have an infection that requires a hospitalization, acute significant trauma or blood loss, or any patient who has shock or critical illness, those patients really need 100 milligrams of IM hydrocortisone if they're getting that by themselves. So if they have a vomiting illness, they should give that 100 milligrams of IM hydrocortisone and then seek medical attention. Patients who present for emergency care should get 100 milligrams of IV, ideally, or IM if needed, hydrocortisone, and then that stress dosing like we talked about, 50 milligrams every 6 hours. So patients who are going to have a surgery or procedure that requires general anesthesia, so they should get 100 milligrams of hydrocortisone IV at anesthesia induction, followed by hydrocortisone 50 milligrams every 6 hours afterwards. Post-operatively, patients can be switched to oral glucocorticoid as soon as they're able, usually within 48 hours or so, and they should have an increased dose of their glucocorticoids for the next couple of days. There's also some recommendations here when women are going to be having a cesarean section or going into labor and delivery. So in summary, we really need to promptly identify patients with adrenal insufficiency because this can be the difference between a patient doing well and a patient not surviving. Cortisol levels above 18 in the morning definitely exclude adrenal insufficiency, although lower levels of cortisol certainly are seen in many normal individuals. You need to use some clinical judgment when interpreting levels, but levels less than about 3.5 micrograms per deciliter are essentially diagnostic of adrenal insufficiency. In this gray area between 3 and 18, cosentropin stimulation testing can be helpful, and a rule of thumb is that a cortisol of greater than 15 micrograms per deciliter at 30 minutes and greater than 18 at 60 minutes are normal and exclude adrenal insufficiency. Remember that when you treat a patient with adrenal crisis, don't wait for lab results. Give them hydrocortisone and IV fluids immediately. And individuals who have chronic adrenal insufficiency, they require 20 milligrams or so in a divided dose for treatment of adrenal insufficiency. And individuals with primary adrenal insufficiency also need fludrocortisone for mineralocorticoid replacement.